a lineup of distinguished speakers to discuss vaccine distribution. It's obviously the hot topic that's been on everyone's minds and in a lot of people's arms for the last month and a half. So we have a panel discussion. We'll be starting with Katie Greene from Duke-Margolis Center for an overview, and then Dr. Michelle Nichols from Morehouse School of Medicine, Dan Hoffenberg from here in Boston, helping to manage the vaccine distribution campaign at Fenway Park, and Kathleen Jager from the National Association of Chain Drugstores. She will be informing us about the big effort now underway through chain drugstores all across the nation. My name is Francis Campion. I'm an internal medicine physician here in Boston and one of the research directors at the MITRE Corporation. We've been working over the last year through the Healthcare Coalition for COVID-19 with a union of about 1,000 private sector organizations and academic partners and health systems, and making really quite tremendous progress. I see one of our co-leaders of the coalition, Dr. John Halamka, and always interested in having John say hello and welcome to the team.
Hey, and thanks everybody for joining today. And what a timely topic. As we've been together now these more than 35 weeks, what we've seen is we've changed topics as the disease progression and response to it has progressed. Today, we'll hear about vaccine distribution, but when you think about this whole ecosystem of vaccines, right, it's everything from how do I register for a vaccine? How do I qualify once I'm registered? How do I get it administered? Appropriate supplies meeting me where I need to get it administered, of course. Then how do I keep a record of what was administered? How do I ensure I get a second shot if I need one? And how do I have personal control over the credentials, the passport, if you will, that shows my vaccination history, should I need that for travel or attending events? So all of us, these more than 1,000 companies, are working on every piece of that particular flow, sometimes technology, sometimes policy, and sometimes in the trenches. So, hey, look forward to the presentation today, FX.
Thank you, John. So we'll get started. We'll ask Katie Greene to put on her screen and take it away, Katie. Katie, you need to unmute, I think. It looks like you're still muted from our side.
I'm sorry, I keep getting kicked off. Can you hear me?
There you go. Now that's perfect.
All right. Apologies. So I missed all that. Am I presenting now?
We're just starting. Yes, and you're on. Thank you.
Great. Okay. All right. Let me share screen, and I do apologize if I end up having some technology issues. Get kicked off. Okay. Can you see my screen?
We can. Looks great.
Okay. Wonderful. Thank you. Thank you for bearing with me. So hi, everybody, and thanks so much for the opportunity to present. My name is Katie Greene. I'm a visiting policy associate at the Duke-Margolis Center for Health Policy. I'm here to give a bit of a national overview on vaccine distribution, particularly from a state perspective. So 2 months into vaccine distribution, where are we? How are states responding to critical challenges as we move to wider distribution of vaccines in the population? So maybe just to start, what is the role of states in vaccine distribution? So states typically handle what we call the last mile of vaccine administration. So they receive vaccines from the federal government. They manage the systems for ordering, distributing, and monitoring those vaccines. And then really they work with a variety of partners to support administration in a wide variety of healthcare and community settings. So at Duke-Margolis, we are working directly with a number of states and partnering with critical organizations like the National Governors Association, the Association of State and Territorial Health Officials, Association of Immunization Managers, to really support the improved efficiency and equity of the vaccine distribution effort. So We have published a review of all state and territorial COVID-19 vaccine plans. We've held a series of convenings with state leaders, and shortly we'll be publishing a white paper outlining some promising practices in distribution, as well as highlighting some opportunities for public-private partnerships to support these efforts. So advancing the slide. So where are we with vaccine distribution? And overall, there's some really good news here. So overall, we've distributed almost 55 million vaccines. Almost 5% of the populations has now gotten both doses of vaccines, and we've increased steadily after some early hiccups where states were only distributing about 50% of the vaccines that they've gotten. We're up to about 1.7 million per day administered. So that's good. It's looking better every day, but at this rate, it'd still take about 8 months to cover the estimated 75% of the population that we'd really need to reach what we need for herd immunity. So this map on the right is the percent of supply used across each states. Some variability here, but overall, we have over 6 states that are distributing upwards of 90% of the vaccines that they receive. The nationwide average is about 78%, and some of the lower performing states are in the 60s. But after some initial hiccups, states are really getting much more efficient in terms of quickly distributing vaccines. And right now, the real rate limiter is just the amount of supply in terms of scaling the number of people that are vaccinated. So in terms of what we know about supply, we've had more promising news. Folks might have seen last week, the Biden administration announced that they'd secured an additional 200 million Pfizer and Moderna vaccines, putting us on pace for 600 million doses this summer. This is in addition to what we think will be the imminent approval of a J&J vaccine within the next 2 weeks or so. So taken together, this means that we'll have enough vaccine to vaccinate the entire United States by the end of July, and may see widespread availability as soon as April. So really 2 critical takeaways here. One is we really need to dramatically ramp up our vaccination capacity to meet these supply, especially given, this is especially important given the spread of more transmissible viral variants. And then right now, as I said, supply is the major constraint, but at a certain point, we'll reach then an inflection point where supply begins to exceed demand, and we'll really need to focus on reaching into communities and encouraging folks to get vaccinated. So just drilling down into that first point, as I said, we're currently at about 1.7 million today. That'll really need to ramp up dramatically to over 3 million people in order to stay on pace and meet those targets that I mentioned. On the second point, as far as demand, the picture is a bit more mixed. So enthusiasm for getting the vaccine has increased really substantially, but there are remaining nuances. We know that Black and Hispanic adults remain more wary than white adults. Rural residents remain more resistant than residents of suburban and urban areas. Republicans tend to be more hesitant than independents or Democrats. And then there is also a gap in terms of educational attainment. So what this really points to is the need for targeted outreach strategies that are culturally and linguistically competent, targeted to beliefs and attitudes, and then delivered by trusted messengers. Looking ahead, I know my time is running up here, but there were really a number of early challenges that states experienced in the initial weeks of rollout, ranging from limited federal resources, a lack of visibility on supply for what they could expect, a slow rollout of the federal long-term pharmacy program, and some real challenges with reporting and data systems. But states have responded pretty quickly to these challenges and implement lessons learned. But a couple priorities that are going to be increasingly important as supply and eligibility increases. First, expanding vaccines into a wide variety of settings that are accessible and convenient. So working with pharmacies, primary care providers, employers, insurers, and others, ramping up mobile vaccination units in community settings, improving data collection and reporting. So not only strengthening systems and interoperability, but really collection of critical data like racial and ethnic demographic data that is currently severely lacking right now. enhancing tools for registration and scheduling. We've seen technology failures and fragmented systems that have contributed to a lot of confusion and frustration. The need to communicate with the public in terms that are clear and evidence-based and also are easy to understand and respond to potential concerns. And the last subject that I want to touch on, I really could have spent my entire time talking about this here, is making meaningful progress on equity. So right now we know that Black and Hispanic populations are being vaccinated at rates that are far below other races. And addressing these disparities is going to take really focused strategies to improve data collection, leverage that data to target resources, address real barriers to access like transportation, lack of internet access or language or ADA accessibility, and really doing the hard work of engaging communities and partnering with trusted messengers to build trust in those communities. So those are just a few things I wanted to touch on today. I'm sure there's much more to talk about, but we'll look forward to the conversation.
Well, thank you so much, Katie. And we are already accruing questions in the chat line. So I would encourage everyone who's online and has a question for the panel to please submit that through chat. And after we have each of the four speakers give their brief remarks, then we're going to go to Q&A and should be able to handle pretty much all the questions that come in. And now I'm really pleased to welcome Michelle Nichols. Dr. Nichols is coming to us from Morehouse School of Medicine, and she was already seeing patients this morning. So I know you've had a busy day, Michelle. Thanks for taking the time with us. So it's all yours.
Well, thank you. So I'm a family physician, and so I had our vaccination program at Morehouse School of Medicine. So one of the things, for a little background, Morehouse School of Medicine is a HBCU. So we're part of one of the 4 historically Black colleges and universities for medical school, which includes Morehouse School of Medicine, Howard University, Charles Drew, and Meharry Medical College. So with that, our focus has always been health equity and leading the creation and advancement of health equity. So one of the things that was very important to us is also ensuring that we distribute the vaccine to people of color, and also to dispel many of the myths that are associated with the vaccination. So as most people are aware, there is an amount of distrust that you typically have seen, particularly in the African-American community, and that was based on just things from the past, like the Tuskegee study and the Henrietta Lack with the cells. And so there was a level of distrust. And so one of the things that we wanted to do was to go out in the community and to dispel that and to make people more aware of the importance of vaccination, and also to go into the community and provide that. So one of the things that we did was, when you look at the disparities, so Katie did a great job of saying that you look at the types of people that receive the vaccines. So you tend to see less vaccinations, particularly among the people of color, in both the African-American community, the Hispanic community, the Asian community. So all of the various people of color, you tend to see less vaccination. Also, as she pointed out, you see it in the rural areas, you see less vaccination compared to the more urban areas. And that's what we've seen in Georgia as well. So as many might know, they initially were not capturing race on the data that was captured when you get the vaccination. So about 52% of the states were capturing that. The good news is that the importance of that has been stressed, and so they are starting to get more people getting that data. So Georgia, for instance, which is where I'm located, started on just 2 days ago, starting to obtain that data as it relates to race. However, with Morehouse School of Medicine being a medical school, we started getting that type of data much sooner. And starting whenever we had our first vaccination program, we didn't, but then we thought it was really important to start getting that data. So when you look at how we compare to everyone else, we have, as of, this was last week data, of the people that we have vaccinated, and that was just for the month of January, we found that 68% of the people that we vaccinated were people of color. They were African American. And we had, as far as white, it was 27% of the population that we vaccinated were white. That is a very stark contrast to what you typically see, which was within our state in general and all throughout the United States, where as of last week from the CDC, only about 5% of the people that were vaccinated were African American. So you can compare that we compared to 5% getting vaccinated, we were looking at around 68, almost 70% of the people getting vaccinated were African American in particular. So one of the reasons that we were successful with that is because, one, we are located in the middle of a predominantly African American community. We are part of the historically Black colleges and universities. We do research, which includes doing a current vaccine study here. And so we had that trust. So that was one of the important things that we noted. Also, we believe in going to where the people are located. When you look at the disparities that you see, particularly with your social determinants, not everyone has a car. So if you're doing a drop-up situation, not everyone can get there because they might not have transportation. So you have to focus on going to where everyone is located. Another thing is many of our population, when you looked at them, might not have computers, might not have internet access. So you have to be willing to do paper, you have to use phones, so you have to do other methods to try to reach the population. And so what we believe is giving people what they need in the amount that they need so that they can reach their optimum level of help. And so with that, some people only need a little bit, some people need a lot. So we found that it's best to go. And so one of the things that we are doing is that we're getting ready to go into use our mobile unit to go into those areas where people don't have transportation, they don't have access. We're also going to use that for the rural communities. Georgia, I live in Atlanta, but when you're outside of Atlanta, it's predominantly rural. So you're going to have less people being vaccinated if they're in the rural areas. And so with that, that is why we think it's real important to go with your mobile units to those areas and take the vaccine to where they're needed. Also, as most people have found, when you look at your senior homes or your assisted living facilities, it is better to go to where they are located because they often don't have those transportation things. We found also that you have to go to, not everyone is able to fill out things on the computers or send out a smart sheet as we have available. And so with that, you want to be able to provide paper, also have someone to explain. Another issue that we found and we were able to tackle was resources. So one of the things with resources is that everyone is looking for nurses to give vaccines. What we did was train our students. So we trained our medical students. We have 100 medical students per each year, so a total of 400 medical students. We have 660 students total. So we trained those students to become vaccinators, is what we call them. So we taught them, we provided certification, we set up a simulation lab, so they became the ones who started going around and helping us to vaccinate everyone. We also trained our Masters of Public Health, our public health students, to become navigators. So they can work with the patients and talk to about different resources. So the key that we found is that you have to give people what they need and the amount they need so that they can have the same level footing to have the optimal level of health. And so those are things that we just said that there's access issues. And so those are things that we said we want to focus on. And then there is the issue of how do you get to the public? Now we're having the same problem that Katie just talked about, is there's a supply and demand issue. We have 8,000 people on our waiting list right now. So yes, there is definitely a demand, and we are trying to get as many vaccines done as possible. And based on compared to last week, we are starting to see that there is an uptick and most people are able to get better access to vaccines, but we still don't have enough. So those are things that we have to tackle. And I know that the other panelists are going to talk more about that, but I do welcome the opportunity to answer more questions afterwards. I see my time is out, so that's why I will go to the next panelist, but thank you all.
Fantastic. Thank you so much, Michelle. We do have a lot of questions coming. We'll move now over to Dan Hoffenberg. Dan is based out of Boston. Dan, maybe you can give us a little background on how you even came to be in this part of the fight against the COVID pandemic.
Yeah, sure. I'm going to share a screen here to some slides. All right. So as far as mass vaccinations go, Cataldo Ambulance is really boots on the ground, what's happening at mass vaccination sites, specifically in Massachusetts. So first of all, who are we? Who's Cataldo Ambulance? We're a local ambulance provider. We're family-owned business since 1977. Primarily, our work is emergency and non-emergency transportation for sick and injured patients. We do about 150,000 transports a year to 20 different cities and towns in Boston and some of the major Boston hospitals. We have 600 employees. We've had about 600 employees very consistently for the past 10 years or so, working out in the field. We got ourselves into COVID testing pretty early on, and in vaccinations, we're going to, when all is said and done, have about 2,500 employees working directly for our company, doing mass vaccinations and mass testing as well still. So Fenway Park specifically, there's a lot of partners. There's a lot of boots on the ground that go into these sites. So our partners are CIC Health, which is the lead contractor for Fenway Park and also for Gillette Stadium, Massachusetts. Their role is complete oversight of the park and of the logistics of the park. Cataldo, we're handling the personnel at the park. Beth Israel Deaconess Medical Center is providing all the medical oversight. So they have physicians on site every single day, giving us direction on specific issues that might arise throughout the day and setting specific protocols. And then DMSE Sports, which is Dave McGivelry Sports Entertainment, which is best known for the Boston Marathon. So they're a sports entertainment company who's doing logistics now for mass vaccination sites in Massachusetts. So all of these partners kind of came together and said, what's our area of expertise? What do we specialize in, and how can we make a difference in mass vaccination sites? So clinical and operational roles. So how we went about it with roles, recruitment, and training of all of our staff. On site at Fenway every day, we run 10 vaccination stations. And in order to run those stations, we have about 50 personnel on site every single day. And these personnel are made up of a number of individuals: check-in stations, resolution desks, greeters, vaccinators, vaccine prep, coordinators, runners, row captains who are just overseeing all of our vaccinators, observers in the 15-minute area, high risk observation in those that are either greater potential for showing symptoms or greater potential for having adverse reactions. And then second appointment booking, we want to make sure everybody that hits that site is booked for their second appointment pretty quickly on site before they leave. So who are these people and what did we do to get them? So we put out a mass call. We started a campaign called Stick It to COVID, which we targeted everybody who could possibly be a vaccinator in the state of Massachusetts. So the state of Massachusetts sent out an emergency waiver saying, here's a group of people that can help vaccinate. And that is everything from EMTs to paramedics to emergency room physicians and RNs to veterinarians, pharmacists, pharmacy techs, and first-year nursing students. So we connected with a number of colleges and universities throughout Massachusetts that had nursing programs. We connected with veterinary clinics, pharmacists, pretty much anybody that we could get our hands on. And in about 30 days or so, we received over 4,000 applications from people all over Massachusetts that were willing to help vaccinate or be on site in any way, shape, or form to help us run these vaccination clinics. So that's how we went about it. From a training standpoint, we set up training that was very consistent across the board. Regardless if you were a first-year nursing student or you were a 30-year emergency room physician, every single person went through the exact same training with us. We ran simulations. We rented space in a hotel where we ran simulations of what that site was going to look like before people entered that site. So, you know, when a guest walks into that site, they're going to hit the check-in station first. If there's an issue with the check-in station, we're going to move them to resolution. When they walk up to that ramp, there's going to be somebody to greet them. They're going to point them to a vaccinator. So we set up this mock drill inside of that hotel to train everybody the same exact way before we actually got on site at Fenway Park. Staff experience. So we recognize very much that this staff that we got on board were the same frontline workers who have been dealing with this pandemic since the very beginning. They're tired, but they still want to help and they're still stepping up. So we need to ensure that we're taking care of all of these frontline workers who are still stepping up. Every morning we have a morning huddle. We get everybody together. I call it the locker room speech. We stand everybody together and we give them sort of a rah-rah speech. We make sure that they're aware of what they're doing. They're aware of what they're participating in. And we ask them to take in the fact that they're going into Fenway Park every day. It was every kid's dream. So I'm going to go into Fenway Park every day and go to work. And what they're doing is making a huge difference. We give everybody very flexible schedules based off their full-time jobs. We ask them to know their customer. We ask them to know their product. And their primary job is to reduce anxiety of anybody that's walking into that site. It's very active management throughout the entire day. We have site administrators on staff that are actively managing our staff. They're speaking to every single one of them. They're ensuring everybody gets a break if they need a break. They're ensuring everybody understands the technology that's involved in booking these appointments and making sure that everybody that is vaccinated is documented. And we have a number of extra staff available every single day to just replace somebody that's just had enough and just can't do it anymore. So we're taking care of our staff. They're our greatest asset by far. And we know we need them in order to make these mass vaccination sites happen. So we put a lot of pride into taking care of them. And then what's that guest experience like? So it's very much know your audience, know what particular phase that you're in within your state, what particular age group that you're serving at the time, what their special needs might be. We're measuring the tack times consistently to ensure that nobody's waiting more than 20 minutes every single day. So we started off very slowly with a tack time. We call it a tack time of 12 minutes per guest per station. We increased that number to 10, then to 8, and now we're at about 6. So Massachusetts is currently doing a 75 plus population, which comes with its own challenges. And we're doing it with a tact rate of 6 minutes between guests per vaccination station that we have open. We're expected to be the experts. I think throughout this entire process, some of us are still building the plane while we're flying it as well. So we're learning as we go along, but we're the experts. When those guests come on site to get their vaccines, we need to know everything about how we're pushing them through the process, how we're vaccinating them. We need to know about that vaccine. We need to anticipate any changes that are going to happen whatsoever throughout a day and remain flexible. So all of these sites are all about flexibility. We've been up and running now for about 3 weeks at Fenway Park. We've probably made 15 different changes in those 3 weeks. Ensure proper customer resolution stations. So there's a lot of issues that happen throughout the day, but these sites are very much based on flow. We have to keep that flow going. We have appointments scheduled. We have X number of people that we need to get through that site every single day on time within their time period. So ensuring proper customer resolution stations where somebody can go and ask questions and get their problem solved is very important to keeping that flow going. And really just never forgetting the significance of the moment for every guest that we see. So just like the ambulance industry, every call is independent of another call. It's somebody else's emergency. So we try to really drill it into our vaccinators and our staff that this is somebody's moment. This is their moment to get vaccinated. They've been looking forward to this moment now for about 10 months. They're looking forward to normalcy and to hug their loved ones again. And we're giving them that opportunity to get there. So every single individual that we vaccinate is special to us. And every single vaccinator understands that and knows that very well. And then it's always be ready for curveballs, not to throw in I had to throw in one baseball pun. So be ready for all the curveballs that are going to hit. Up here in Massachusetts, first day of our mass vaccination site, after our soft launch, we had a blizzard. So what was going to happen on that blizzard day? So we extended that day. We canceled morning appointments, or we postponed morning appointments. We extended that day. We went well into the evening that day after the snow fell. What that brought on that first day was what we're calling vaccine seekers. So these are folks that understand that there might be leftover vaccine at any mass vaccination site at the end of a day. We know internally that's not really the case. We manage our vaccine very tightly to ensure that we're not wasting a drop of that. But there's inevitably a number of people that are going to gather outside at the end of every day, seeing if we have some leftover vaccine to give out. So it's, ensuring that we set standards that, this is how it works. That's not going to happen at these sites. It's very strict on how we're giving out this vaccine and how we're booking appointments within phase. Translation services. So we thought we had it figured out. We had language line for a number of different languages that were going to be spoken. On the second day, we had 45 Mandarin speaking, a group of 45 Mandarin speaking people walk in all at the same time. Handle that situation. We closed down 3 stations. We just put them through those stations. And we continued on with everybody else to vaccinate them in our normal cadence. Quick changes to phases and groups, who's being bumped up, when we're going to hit the next phase and the next group to vaccinate them. Managing vax on-call lists. So every night we're going to have potentially 5 doses left over of Pfizer vaccine. Who's on call to ensure that we don't waste a drop of that vaccine. It's our most precious commodity right now, and we're not going to waste it. Dealing with media coverage, dealing with VIP visits. We've been on the Today Show and Good Morning America and MSNBC and CNN, and everybody else has wanted to see what these sites look like and walk through these sites. So how do we continue just vaccinating the population throughout all of these interruptions that might happen on site? So these are just some of the things that we're working with, boots on the ground. I really appreciate your time and look forward to any questions.
And that's fantastic. My own internal medicine practice is right in the neighborhood around Fenway Park, and it's been fascinating to see the volume coming in. It's almost like a game day every day.
Yeah, it's quite interesting right now.
It's absolutely fantastic work, and thank you for what you're doing. We'll now turn to Kathleen Jager. She's Senior Vice President at the National Association of Chain Drugstores. And Kathleen, your organization has also reached out to take on a big task, and we're looking forward to hearing you tell us about that.
Well, thank you. And thank you for the opportunity to be part of this panel. So really, I appreciate all the great work everyone's doing on this panel and all the healthcare providers out there. So for those that don't know NACDS represents the trade association and represent all the drugstores across America. So that includes all the traditional drugstores that you can think of, like the CVS, the Walgreens, the Rite Aids of the world, but also all the grocery stores that have pharmacies within, and also the big box stores, so like Walmart and Costco, all the way down to regional chains that have 4 or more pharmacies. So we represent about 40,000 pharmacies across the United States, and we're located, of course, in urban areas and medically underserved communities, as well as in rural areas. And in some situations, we are really the primary destination for healthcare for some individuals. Some of, as you know, some of the most vulnerable folks in America actually will visit a community pharmacy more so 35 times more than they will actually their primary care physician about 7 times a year. So with that, and we think about pharmacies, you're thinking about 91% of Americans live within 5 miles of a community pharmacy. And so there you have access, you have convenience, and you have trust. And pharmacists are really a very well trusted, as everyone knows, a healthcare professional. And we've been working really as part of the public health infrastructure in terms of public-private partnerships with the federal government, with state governments, and with local counties, really looking at how we can maximize the existing partnerships that we have in place to do response and recovery. We do that, as most of you know, we work with all the public health groups in terms of disasters, whether it be a hurricane or tornadoes at the same time, we on Zika. So we have really had a very strong infrastructure with public health, including CDC. And from that, we've been able to leverage that in the response. I think, as most of you probably aware, our pharmacies started off with COVID testing, doing the mobile COVID testing in the very beginning of last year. And then we moved through the year into surge flu vaccination opportunities. And there we started to take the opportunity to really start to educate those in the community about the COVID-19 vaccines that were forthcoming, to making sure that we could start to really eliminate some of the misinformation and correct that information in those communities, and getting everyone ready to go into the COVID-19 vaccination initiatives. And as everyone's mentioned, pharmacy is part of those initiatives right now. Pharmacies are either in the federal program, which is a pharmacy partnership program with CDC that just commenced last week. And there we had a soft launch last week where about 1 million vaccines went through the allocation through the system across the United States. We will have it be ramped up 2 million this week. And then as we move forward, the dial will hopefully keep on turning. At the same time, pharmacies also have been engaged with states. So they've been working right with the state partners and the local partners in their communities to basically be very synergistic to their mass clinics that are ongoing, that Dan just mentioned, and other special clinics for healthcare providers. And so we've been working with the states to roll out vaccine distribution initiatives, and those that are most vulnerable. Ensuring, really looking at opportunities to ensure that we get that vaccine to the most vulnerable so that we can hopefully push really hard on health equity here and as we move forward. So when you kind of stop and take about the infrastructure here with pharmacies in the nation, you're talking about 40,000 pharmacies. You're talking about if we only did 6 vaccines in a given hour and over the course of a 12-hour day, you're talking about 316 million vaccinations that can occur in 1 month. If you have 2 vaccinators, when you use technicians or nurses or other healthcare providers than physicians in our clinics, you're talking about doubling and tripling that. So at the end of the day, to Katie's point, it's not about vaccinators per se. It's really, we have plenty of vaccinators in the United States. And we actually have plenty of vaccine sites across the United States. What we don't have is we're really constrained by the allocation. So that's what we're looking forward to, is getting more allocation from the manufacturers and then being able to take that allocation and bring it that last mile to get it to those that are really in need. So we have clinics that are running right now at the state level and also now starting at the federal level, and they range from appointment-based systems in stores. So those are people going on and getting an appointment, and when they're registering, they're finding out if they're eligible for that vaccine in that county and in that state. And if they are, they're allowed to move forward in the appointment scheduling system. And then they move forward and make 2 appointments for their first dose and their second dose if it's a Pfizer or a Moderna vaccine. And then hopefully as we get to J&J, we'll have that one appointment. But then you go through and you get the information, you get reminders about when your appointments are. And when you come into the store, you're met by a greeter, you're checked in, you move forward and through the system. And it's very, very seamless. And you wait your 15, 20 minutes for observation, and then you move on. So it's a great way to make sure that we're social distancing. At the same time, we're being very efficient and very effective in utilizing the IT and all the other operational efficiencies that we have in our system. And then making sure that we can answer the needs of the individuals as they're coming through. And if any questions, we're helping them resolve those issues and their concerns. At the same time, we have members that across the United States that typically do flu mobile clinics. and other types of vaccination clinics, and they go out into the communities. We have members, some of our regional members are out actually knocking on doors and bringing vaccines to those that are most vulnerable. One example is we have one of our members, Fruth Pharmacy, has been working with the state and the local partnership, getting allocation through the state. They actually know their population extremely well. They had clinics inside their store. At the same time, they are going to those communities in the mountains where people don't have the transportation, and getting and knocking on those doors of those 91 and 98-year-olds and giving them their vaccine right there at their home. So we have a lot of interesting combinations in here, and we have a lot of opportunity to do more. And our members are actually very looking forward to doing more as the allocation comes in. And so we know that access is absolutely key, and we know trust is certainly a very, very important variable, and also making sure health equity. Inside our systems, all our pharmacy systems, whether it be state or federal, we actually do capture race. We also do capture all the demographic information that CDC is asking for. So we'll be able to track that. At the same time, within the Federal Pharmacy Partnership Program, there are metrics. And so as we move forward in that system, you'll be able to see whether or not we're hitting the right demographics, we're hitting the right populations, and the throughput. And we really welcome the opportunity to have these performance metrics so that we know we're doing it right and we're getting to the right population. So I look forward to, there's lots of questions I'm sure your listeners have, and I'm very eager to answer those questions. But thank you.
Thank you. So I'll ask each of the panelists to turn on their cameras. And we do have a good number of questions. One is regarding adverse drug events. And what's striking, honestly, is that none of you have even had to mention that. And that probably is a testament to the safety of these agents. But just wanted to know what your plan of action is and what the documentation looks like. And will we systematically be gathering data around adverse vaccination reactions that will be beneficial to CDC? And do we have a systematic approach? I think that's the key.
So one of the things that we do for every patient, we register them for Be Safe. So that's the CDC site that you register. Since our patients, they're elderly, we actually have our students or our different team members, when they're in what we call our final station, which is the observation station, we actually help them put that on their phone. So we will go and show them, and that will be one way of monitoring. We always have a site set up so that they can call a number to also ask questions. In the actual observation period, since we do have students, but we have our providers, we have all types of people there. We have everything set up for any type of emergency, whether we're in our drive-through site or in our clinic. The clinic is naturally, you have everything there. But we're in our drive-through site, and I'm sure that Dan would talk about that too. We have everything already set up. We have the AEDs, we have the oxygen, we have the EpiPens, we have everything, we have the Solumet, we have everything ready for any type of emergency. So we bring that and we take that to each one of our sites, but the clinic is already there. But the main thing is we have made sure we register people for Be Safe through the CDC site, and we explain the process to them. We also give them the handout. And so that is one way that you can monitor any potential side effects.
Fantastic. Katie, have you seen any of the national statistics that relate to safety? It seems like things are going quite well.
Yeah, no, this is not something we've really focused a lot on, which, as you said, is probably a good thing, but I would certainly defer to the folks on the panel with an MD next to their name on those issues.
Okay, second dose scheduling has been a great concern. And this gets into the data and the tracking. A lot of our listeners are calling in from health systems. And I think there's a lot of concern out there that a person who's walking out, say, with their little card that tells that they had their injection today, that if they lose that card, there may be a loss of information as it relates to timing for the second dose, and maybe even making sure the patient gets the correct vaccine. I just wondered if any of you could comment on what you're doing to put those checks and balances in the system you're using.
So maybe I'll jump in here. With respect to the pharmacy systems, you, as I mentioned, you have a first appointment and your second appointment. You actually, for the most part, are actually making those appointments before you get your vaccine. And then you're getting your reminders for your appointments. And then after you get your first dose, you're going to get the reminder there at the time that you're getting your first dose when your next appointment is. And then you're going to get a couple more reminders to make sure that you're remembering to come and understanding that, you know, which vaccine did you get, and making sure you're coming back to that appointment. So the system is kind of built in to have a lot of different reminders put through. At the same time, they get their cards. And to what Michelle's saying, that, you know, everybody is encouraged to make sure that they actually enroll in the Be Safe program. At the same time, get back to their healthcare provider if there's any situation or having to do with safety or efficacy.
Yeah, on the end of the at the mass vaccination sites itself, we're scheduling everybody for their second dose before they leave that site. We have about a 98% second dose rate, where they're scheduling that appointment before they leave. A few of the things that we encountered right off the bat were, number one, we were dealing with a 75+ population that was very difficult for them to navigate through the technology to book that second dose. So our observers in that observer area are actually walking around with iPads and have laptops on wheeled carts that are helping that population book their second appointment while they're in the observation time. So we're doing that right on site for most people at this point. And that's helping tremendously. Same thing, reminders are going out. The other thing we encounter really quickly is we're doing Pfizer, and the guidance is 21 days for Pfizer, 28 days for Moderna for that second dose. That scheduling system literally just had that one day, 21 days out from the day of their first dose and 28 days out from the day of their first dose, depending on the vaccine you were giving. We had to open that up, obviously, to allow them to choose other dates that weren't strictly 21 days out. So somebody might be on vacation that 21st day, but they're home by the 23rd day. Well, that's okay. We can still give you your second dose that day. We just didn't have the scheduling system opened up initially to allow them to choose that date for their second dose. So just a few of the hiccups we encountered right off the bat.
So something we did is we tell everyone to take a picture of your card. So we tell everyone, because you don't necessarily have to go to the same location for second dose. You know, most people do. And so that, therefore, we just tell them, we know that things happen, you might lose your card, whatever. So we always, that is before they walk out. If they're elderly, we'll ask a family member for our very elderly to just take a picture of it. So at least you'll have it.
That's great. There's a few questions in the chat that relate to the data flow within the electronic health record system. And I wondered if any of you could comment. You have very disparate places that you're doing your activity. Just wondering, how does that data flow locally into the standard or the traditional electronic health record?
So I can speak for us. We have Epic, which is probably the most universal, but the most popular type of EHR. So we do have so that it does flow to grids. So for us, our registry that you go through the state of Georgia, so you have to put that input. So we already have that type of interface, but we also go and make sure and check to make sure it entered into that registry. So that's how we do it. So the appointments that we do clinic naturally are already scheduled, but even when we do our community vaccination programs, we still put all appointments into our EHR. So everyone will get appointments. So we might, like last week, we had 620 something people on a Saturday put into the Epic system. And so that way you check them in, you check them out. We also have a local tracking system, probably similar to what Dan does, so that we have used iPads and all the other stuff. So you're walking around and putting all that information in as well. So mainly that's what we've done it through we schedule appointments, book them in there, check them out, and then it just flows over into the registry.
That's great. I'm wondering if you could talk a little more about the challenges you're seeing as it relates to health equity as far as patient education and getting patients to make their initial appointment. Seems like right now each of your sites seems to have a good number of patients still waiting. How are we making sure that those initial patients are activated from all the risk populations?
So for us, we had to, because the wait list was so long, we then had to just limit it to our county, which is Atlanta, for Fulton County. So we kind of were able to go by zip codes and eliminate that. So if you look at zip codes, that is one way that you can look at it, because a lot of times based on the population. But for our clinic, it's very easy because of the patients that come to our clinic, we have that information. But we open it up to everyone. But I think because of our location and focusing on certain zip codes, you're able to get that access. And then the other thing, as we get ready to go into more rural areas, that's the same thing that we're going to do, is look into the demographics, and zip code seems to be the best way of getting, for us, that data based on where people live. Although anyone can live anywhere, but we found that zip codes works very well.
And Michelle, what are you doing for the patients that don't happen to be in your electronic health record? You must be getting some.
We're getting, no, most of them are not they're not our patients. So we're getting new patients from this, but no, they're not our patients. So we register everyone. So as long as for the first one, if they make an appointment, and we develop a smart sheet, so we have a link from the Department of Public Health, put us as a link, and then they were able to go into the smart sheet. Plus there's a phone number, but once that went in, we actually take every single one of those that we make appointments with. We will give at least the basics. We get more information later on, but just the basic name, date of birth, and phone number. We'll do that. And then when they come in, we're able to fill out more of that data.
Right.
I think one of the problems that we've seen is that even if some of these locations are placed in underserved areas, if they are open to everybody, a lot of times the people that make those appointments are the people that are able to navigate those systems and are willing to drive long distances. So some of the strategies that we have seen people do to sort of navigate around that is to engage community-based organizations to do the outreach, having essentially call centers that are reaching out to targeted populations. Limiting by zip code is another thing that we've seen, and creating a little bit of almost like a pre-registration opportunity before those are offered more widely.
Yeah, what Katie said is really right. We've engaged the churches, because that is a great way where you can have the outreach. And so that's one of the Black clergy, for us, has been a very good opportunity. Also for our Latino population, we've dealt with like the various consulates and worked with them. So you can outreach. And so that way you want to ensure that you hit the populations that need it. And you always want to leave open appointments available to make sure that you get the different various populations. Like I said, the church, someone from a church or a certain area might say, we really, really need to get that. So you don't want all your appointments to be grabbed, because people who are more tech savvy will grab those appointments up. And so you can't just not give it to other people who aren't tech savvy. So that's one of the things we found. And also we do take, at the end, you don't want to waste any vaccine. Like Dan said, I mean, so you really start reaching out, and a lot of people already have a list of people already that they know that they're really able to, that are 80-year-olds, 90-year-olds, that no one else will be able to reach out to them. So most people that work the site already have that list of people that they want to call, and they kind of let them know that be on the lookout. We'll call your family.
I just wanted to say that we kind of share the same kind of concerns too. If you've got some people that are just so tech savvy and they can navigate the system, they're able to jump in earlier. And so and zip code seems to be the way, to really start to track a little bit if you can limit it by the zip code. But the other problem also is that so much right now, there's so many clinics right now that are just one either for 65 years and older, or just healthcare professionals. And I think that also that causes a lot of different confusion and frustration for so many, depending upon the state, how the state runs their programs. It's not that you have a site that might be open to all. It might be very, very limited. And so from that standpoint. And then I have one of the questions here about the pharmacies, and we apologize for the frustration. I think there's unfortunately, there's so many people who really, the demand is so strong, but the supply is so limited and it's so scarce. And the amount of supply coming through pharmacies is just not flowing enough to get to all the communities. And so the appointments are going within an hour to 2 hours, depending on the system. And it's just frustrating for so many, so.
And what Katie mentioned regarding pre-registration, I think, we're starting to rethink how we can deliver vaccine to various communities through pre-registration. So, how can we stand up mobile units that can strictly go into community for 1 week or 2 weeks with a preset list of individuals that signed up weeks ago to receive their vaccine during a certain time frame that we're going to be in that community. So we can set up a trailer full of everything we need and go to a location for a week and stand up that location, as opposed to a mass vaccination site where everybody's coming to us. We really need to rethink getting out into communities with less access to get to these mass vaccination sites. So, and that's what we're starting to work on now, is getting into either directly into people's homes or directly into their communities, whether it's a church or wherever. So.
Great. Wondering if you could expand on the topic of the mobile units and how you're setting that up, whether that's through a traditional ambulance or is it a home-based delivery? And I know, Michelle, you were talking about your mobile units as well. So I'm really interested in this topic, because that is certainly getting to the last mile to get the person who really can't come in.
Yeah, so if you don't mind, so there's two types of mobile units I think people talk about. One is a mobile vaccination site where I'm putting everything I need into a trailer and delivering it to a specific location within a community and setting up a site, within a day, and spending a week there and moving on to another site. The other is real mobile home care, in a sense, where I leave their home but needs this vaccination. So in both models, we're discussing both, some with major hospitals in Boston. For those bed-bound patients that to serve their populations, it would literally be going to the hospital, picking up 4 doses of pre-filled syringes, going out to the homes of bed-bound patients, delivering them within the 6-hour period to make sure none of that vaccine goes bad, and then going back to the hospital, picking up more and going back out. So of these 4,000 people that applied to us, we put out a call and said, how many people might be interested in using your personal vehicles to deliver vaccines out to the community? We got about 150 people that said, we'll absolutely do that. And it's just centralizing where we can pick up those vaccines and the radius around the pickup location of those vaccines, and getting out to bed-bound patients. We're calling them more than homebound patients, those folks that really need them within their homes. But so those are the two sides of mobile vaccines that are being discussed, I think.
That's good.
Oh, and we're the same way. Well, this is our next phase, but yeah, we have a mobile research vans. We have several of those where you just drive that big van with all their supplies and you go into the area that you need. So it might be a different type of senior home. So you can just take all those supplies there and you go, and then you will vaccinate those people. So that's how we do it. And so we're just using our mobile units, and we've used it for other things because we have different types of clinics that are what we call free clinics that we have gone to the rural areas. And that's pretty much like you said, you just go, you set up at that site and you work. They know to come to that site or you go into that neighborhood.
And just to add in, yes, and our members also do actually have, as I mentioned, mobile clinics for special vaccines, flu vaccine initiatives that they go into the actual community. The community knows they're coming on a given day, and we just set up mobile clinics there. At the same time, we also have, as I mentioned, we have some regional members also working with the state to actually do the knock on door homebound concept, because they're not, these older Americans aren't in nursing homes. And but yet they might not have transportation, and they may be very old or fragile and can't come out. So a lot of different creative, innovative initiatives that are out there. And I think it's just, again, it's more about the constraint of supply than actually everyone getting out and doing and executing. I think there's a lot of folks that want to execute. We just can't execute quite yet.
Well, that's great. Our hour's coming to a close and we've learned a lot. I'm just so impressed with the innovation that you've all described and the hard work. And we know everything that's been learned already is going to prepare us for next, but things are going to keep changing. The virus itself is now bringing us mutations. There's a certain degree of uncertainty, but what's impressive is the trust that each of you is building with your constituencies, because that's ultimately vital when we face uncertain times. So thank you for each of your everyday work, for leading your own organizations, and for your willingness to share it with us today. I'm sure the listeners today are going to bring back best practices and put them to good work in short order. Next month, on the 17th of March, we'll be addressing another challenging pandemic topic related to behavioral health and equity issues. So that's 2:30 Eastern Time on Wednesday, March 17th. We look forward to seeing you then. John, you've turned on your camera and looking forward to any closing remarks.
Well, just as we look at variants, and of course, FX, this is also a big topic that I'm sure we're going to discuss going forward. We recognize that we need societal resilience. So what we've heard from our panelists today is preparing us for whatever comes next. And I think that these lessons learned over the course of the pandemic have a silver lining, and that is we will be far better prepared for any variants or any future pandemic. So I thank everyone for their work and look forward to being resilient together.
Thank you.
Thank you.
Everybody.